Doug Nunamaker. I'm a family physician from Wichita, so the first Minnesotan, I guess. Is it Minnesotan? Is that how you would say? Okay. Yeah, hi there, hey. If I seem like I'm speaking fast or kind of wobbling, I'm kind of favoring a tenderfoot from a race I ran. Plus, I'm also currently assessing my capacity for used coffee. So there are a number of things, as you hear routinely. I can expand on a number of things that everyone else has commented on, and we can speak for hours about any of these issues, but I just wanted to kind of talk about a little bit about what I bring to this conference, what I've been able to accomplish with my clinic in Kansas, what we've been able to do for other physicians around the country, and hopefully just bring something thought-provoking to all of you. Usually, I'm with my partner, Dr. Josh Umber, from the clinic. We have kind of a dog and pony show, though neither of us can say who's which. And we have a pretty good banter back and forth. Typically, we do kind of a question and answer, so if you do have a question, we usually ask it, but I think it's better saved for the end, just kind of for everyone. First of all, I do want to actually say thank you to Jeremy and all of the staff. Jeremy Snavely, who has helped put together this, has done a wonderful job. So I've been to several conferences now, and he's just amazing at everything he does. So to give you a little bit of background, my father was a hospital administrator for about 40 years for nonprofit hospitals until he retired. He received the Friend of Medicine Award when he retired from Oklahoma, the Oklahoma State Medical Society. So he was actually an administrator that was very physician-friendly. I therefore got my background in medicine and the business of, and medicine is very much a business and always has been, though we've forgotten about that, and consumers don't see it as such. That's where I come from. I'm not coming from a background of business or physician parents. My partner, Josh Umber, his father was a trash man. Now he's a lawyer, but he still tells people he's a trash man because it's less embarrassing. So he has a business background, and we've put those two together to form what we've done. So basically, AtlasMD, my clinic. I graduated residency in family medicine, went into hospital medicine as a hospitalist for a couple years as the clinic was being established. I realized how asinine insurance-based medicine is. Coding, billing, everything that comes with it. At one point, I was about $140,000 behind the rest of my partners in our billing. I asked why, and they said, well, initially you were given the go-ahead by Medicare, but they realized that there was a paperwork error, so they've rescinded that. So now I'm over $100,000 behind all the rest of my partners, and it took 6 months to fix it, but you can only back bill about 1 month. Well, my bonus as a hospitalist was based on collections, not billing. So a clerical error by someone who's paid to do paperwork almost cost me my bonus for the year. So luckily, we had a very forward-thinking and nice hospital that ended up just covering that. But that's where I really started to see the problem. So our clinic is completely outside of insurance, and just like the slide showed earlier, there is the patient and the physician. That's where it should be. The patient and insurance, that's an entirely different entity. They're parallel products, just like car insurance, for example. Car insurance doesn't pay for gasoline. Gasoline's inexpensive. But let's just say that gasoline is paid for by car insurance. Okay. There's no Marquee outside the gas station, so you have no idea what it costs. The guy at the pump next to you has a different rate because they have a different insurance plan. You won't know what you actually paid for 2-3 months until you get your EOB from your car insurance company, so you don't know what you just paid for the gas you got. You were previously told where you could get the gas and how much and what grade, And if you're thinking about taking a trip out of town, you need a PA. You need to go ahead and give them a call and pre-authorize the trip out of town. No one would put up with this, and no one does. We don't insure for fuel. We don't insure our homes for paint. We insure them for tornadoes or hailstorms or fires. Paint is inexpensive. So why do we insure primary care? And people don't realize when you pay for, let's say you have the sniffles, you go and see your doctor, you pay your copay, and then they bill insurance, and the premium that you just paid, well, you just paid for your doctor's visit, but you did it in the most insanely expensive and catastrophically complex way that you possibly can. So we see people based on a membership. There are two ways to do it: fee for service, charge people as they come, or a membership. We chose a membership style practice because now we're not volume based. We can see people, a limited number. We limit to about 500 or 600, although on Wednesday, actually one of Josh was actually in Atlanta at the Consumers and Healthcare Conference speaking. So we had 2 physicians of our 3-physician practice in the office. I had one patient scheduled for 4:30 and she didn't show. So I have about 550 patients and I didn't see a single one. Now I was emailing and talking with patients on the phone, but I didn't see anybody. So I could probably see more than that, but it was kind of a guess. So 500 or 600 patients roughly. Children up to 19 years old, $10 a month. And I'll see them as much as they need. Doesn't matter if it's none or 10 times, I'll see them. Came in last Sunday, kid fell, actually I was over here, fell, hit a chair, had a cut. Ready to sit down for dinner. Patient called me, said, hey, I think they need stitches. I said, fine, send me a picture. Did. Said, yep, that needs stitches. So I came in. So 45 minutes out of my weekend, I did stitches. Well, I work in the ER too. I know how much that's going to be billed out for. Well, at $10 a month, even on the cheap end, $900 to $1,000 for that ER visit, if I just saved him 100 months worth of membership, do you think they're ever going to leave? They see the value. It makes sense. So adults are anywhere from $50 to $100, $50, 75, or 100, just depending on age. But again, you can see me as often as you need. You can email me. And a lot of times it's amazing people that say, well, I never see the doctor. You got to talk to me a lot for never seeing the doctor. Well, it's because you can email me or you can call me. The patients do get our cell phone, but because of our software, and I'll talk about that a little bit, but the software we developed, it's not our actual cell phone number. It's kind of a virtual internet number that if someone's abusing it, we can just burn it, get another one, and then the patients we want to keep, we just give them the new number. So when people can talk to you whenever and however they want, it makes sense. I mean, if somebody has poison ivy, do I really need to see you in the clinic? No, I can tell you, hey, I think I think I have poison ivy. Is this poison ivy? Yes, that's poison ivy. Do you want me to call prednisone in, or do you want me to get it for you ready here in the office? So every other service industry, plumbers, mechanics, electricians, they all work like this. Your car's broken, take it to a mechanic. If their prices are outrageous, you go to a different mechanic. But you know how much it costs. You don't have to wait. You don't have to go to a mechanic and say, hey, something happened, I don't know what it is. And a mechanic doesn't have to look at what's going on and say, well, it looks like the axle kind of exploded in the distal end in the last 13 centimeters of the axle, so therefore we're going to need, no. Broken axle, fix it, $100. That's it. There's no billing, there's no coding as far as how we do it. It's just an invoice. They know what everything's going to cost. Why don't we work like that? And that's kind of where we started. Mentioned earlier was the fundamental difference between concierge and direct primary care. Concierge and direct primary care have a lot of similarities. One's just a lot more expensive. Josh and I were in a Bloomberg Business Week article. The title was rather unfortunate. It said doctors that you can't afford, which we were really irritated with. But the point was looking at concierge physicians, but it started out with talking about a patient that I had. She was incredibly fatigued, had 2 jobs, had trouble paying the bills, couldn't figure out why. So I said, okay, at your age, you're $50 a month. Well, she came in kind of the last half of the month, so I just prorated. I said, tell you what, $25 for the visit. I talked to her about everything. I said, let's do some blood work. Well, we have a direct purchasing agreement with the labs. Out of curiosity, how much do you think it costs my patients for a CBC? Any idea? Yeah, $1.87. So for $1.87, I can get a CBC. For $4, I get a TSH. So I did some very basic stuff. Well, her TSH was 225. Highest I've ever seen. I said, well, I think I found your problem. So for a few dollars in labs and a generic prescription, she still hasn't gotten to her $50 that she thought it was going to cost. Now she has all the energy she ever thought she needed. She's back to normal. She's euthyroid now. That's how this article starts out. Then it goes on to talk about these physicians in Indianapolis, who I won't mention, or name, I guess I'm mentioning them now. But they said, some of our physicians will gladly forego a second vacation to have me as their physician. Like, some of my patients don't have a vacation. So that's really not practical for a lot of people. If I market to the 1%, well, great, if I can make it work. The problem is, if I market to the 1%, I can only ever expect 1% of the market. That's pretty limited. When you exhaust that 1%, you don't have much left. So we wanted to market to everyone, make it inexpensive, be valuable but inexpensive. And there is a big difference between cheap and inexpensive. So communication, that's another thing, being available. Again, 24 hours a day, I'm available. Even now, I've been getting, if you've noticed, I've been getting texts. I've been answering patient questions. Some I send to my staff or my other partners. By the way, out of a 3-physician practice, we have 1 full-time nurse and 1 part-time nurse. That is our staff. That's all we have to pay for. There's a clinic just south of Wichita, an insurance-accepting clinic, has 6 physicians and 62 staff. They cannot support themselves. So for us, you remove all of the billing and coding and the MAs and everyone else that has to shuttle people through, and you just have a much more efficient system. So communication, you give a surgeon a better scalpel, you make him a better cutter. I'm a family doctor. I can talk to a tree stump for hours, much to my wife's chagrin. But if you allow me to communicate with patients and establish a relationship and feel like I'm part of what they want, what they need, and feel like they're looking for from a physician, I'm going to take better care of them. There are things that I get in emails from patients that they would never tell someone in person. And usually, by and large, it's psychiatric. There are things that people say, I feel like I'm just ready to jump off a bridge. I just can't do this. But they never feel comfortable enough saying that in person. So I can kind of talk them off the ledge, even in emails, and if that works me towards getting them into the clinic, great. But these are things that they never had an option to do other than just a crisis line, a suicide hotline that they probably aren't going to do because they don't know who's on the other end. Unfortunately, the current system, it's good doctors practicing bad medicine because of a broken system. So in medicine, the customer is usually right. I work in the ER. I have patients that come in all the time, parents that say, I think my son needs antibiotics. I go, okay, why? Well, he has spots on his throat, strep. Maybe. Could be viral. Well, he needs antibiotics, right? Which one? What dose? How often? For how long? What bacteria are we targeting? They don't know. They just know they want antibiotics. Like, okay, fine. I'll give him amoxicillin and some Tegretol. Like, what's Tegretol? What's a seizure medicine? Does he need it? No. He doesn't need the amoxicillin either. So just because you think you want it doesn't mean he needs it. So it kind of, it's my way of, you know, somewhat playfully playing back and making my point that, you know, look, in my opinion, and, you know, everything else notwithstanding, I don't feel that this treatment is necessary, and I'm going to explain why. I don't have to write you an antibiotic, you know, a prescription for a Z-Pak for a sinus infection that I know is viral, because that's what's going to keep you happy, and it's going to buy me another 4 or 5 minutes with my next patient. I don't have to do that. I can sit down and actually talk to you about why I think you don't need this antibiotic and the possibility of an adverse reaction to it. So a couple of the things we can do for making things less expensive. I'd mentioned medications. Minnesota, Wisconsin, both no license required to dispense medicines. How much do you think a bottle of 1,000 Prilosec 20 milligrams are? Any ideas? Anybody? $55. So for $55, I can get 1,000 Prilosec. I dispense them to my patient for cost. 9 pills of Imitrex. 7. How about Zofran? 4 milligrams IM. Give you a shot of Zofran because you have nausea from a migraine. 24 cents. So I can treat you, bag of IV fluid, about $2.50, $3. I can treat you for these things in my clinic inexpensively. And I can do so because that's the way it should be. I shouldn't have to mark it up. You're paying for my clinic through the membership. Everything after that, why should I make money on an EKG? To you, it's a bunch of squiggly lines. If I keep saying, I think you need an EKG, it's like going to my mechanic and he says, you know, your flux capacitor's out again. That's the 3rd time this month. So they don't know what they need, but if I make money on it, then they kind of wonder if I'm financially driven to get it. If I don't make any money and they know that, then they have a much better understanding of why I want it, because I think they need it. So labs you can do, and we're actually working on national pricing through Quest and eventually LabCorp for all of that through our EMR. You can do imaging. We actually have a local orthopedic clinic. We do plain films, joints, pretty much everything between $25 and $30. For them, it's just like Orbitz. They have an x-ray tech, they have x-ray. If there's nobody in it, they're not making any money. So they'll shoot an ankle x-ray for me for $25 and call me with the result versus having an empty machine. Orbitz sells half-price hotel rooms because an empty hotel room makes nothing. So those are the things, having a good relationship, because if I send someone over and they have a broken ankle, who do you think I'm going to have somebody, you know, have fix it? It's not going to be some other orthopedist. It's going to be the people that I have a relationship with. So to them, it's going to be, and it's cash on the barrel. They bill me. I do $1,000 worth of x-rays. They bill me. I send them a check for $1,000. No insurance. They cash it, and it's done, just like business should be. So the biggest problem with healthcare right now is there's not enough people in it, and there's not enough people that want to go into it because it's broken. How to fix it, that's a complex issue. I went into family medicine again because I'm a talker. I enjoy I had about 6 different things I wanted to subspecialize in before I finally picked family medicine because, again, I knew I wanted to be in primary care. That's my passion. ER, it's fun. Delivered a baby in the ER, and the nurses, I got a little bit of placenta on my shoe, and the nurses wanted to buy me new shoes. And, you know, it's interesting. It's fun. It's challenging. But I never see them again. Unless they're sick, and that's not when I want to see people. I want to know how they're doing when they're well. So getting people into primary care, and we've heard from many medical students, that we've kind of reignited a dismissed passion or interest in primary care. That's what we want. We want people to want to go into primary care. If nothing else, we even want people to go into medicine. You know, this is not what it used to be as far as how people observed physicians in the past. It's changed politically. People think that we all work several days a week, but play a lot of golf. We all drive Ferraris. That's not true. Physicians went into medicine truly to help people, even though it sounds cliche. We need people back in primary care, and doing something like this is really what can help. Trying to document like that, that's another issue. Like I said, if you guys have any questions about the electronic record that that Josh and I have built, I'm more than happy to talk to you about that later. It can dispense, bill, chart, everything. No codes. I haven't coded anything in 3.5 years. Can't be happier. Actually, when I was a hospitalist, we were told instead of malnutrition, can't code for malnutrition anymore. We have to code for protein malnutrition. Fine. Okay, we'll code for protein malnutrition. Then the Kansas Department of Health and Environment came in and asked why there was an influx of kwashiorkor to Wichita, Kansas, and we said, I don't know, that's what you told us. Now it's protein calorie malnutrition, because protein malnutrition codes out as kwashiorkor. So, you know, ICD-10 is going to be no better. Anyway, I appreciate your guys' time. Thank you very much.